Good morning, everybody. The topic of my talk is end-of-life perspectives in patients on hemodialysis. Not a very joyful message on a Friday morning in May, but I think it's a very important topic to talk about. We see more old and frail patients on hemodialysis with several symptoms, as we heard in the previous talk. I will say something about conservative active care or renal replacement therapy, something about advanced care planning, but I will spend quite a lot of time on qualitative analysis, which we don't discuss so much in these meetings, and that is on thoughts and feelings relating to death and dying when living with hemodialysis approaching end of life. We see As people are living longer, nephrologists and nurses are responsible for a progressively older and more frail cohort of patients with substantial comorbidities. And other contributing factors are increasing prevalence of diabetes and hypertension, and earlier recognition and referral for end-stage renal disease. This is the mean age in the prevalent patients with end-stage renal disease in Sweden from 1991 to 2017 is from the Swedish Renal Registry. You can see an increase in the mean age in all patients, but a stable mean age in patients on hemodialysis from 2006. And this is the age groups of prevalent patients in the same registry. You can see an increase in the oldest age group of patients on hemodialysis from 1991 to 2017. So how do we define a phenotype of frailty? The characteristics of frailty include shrinking, weight loss, loss of muscle mass, weakness, poor endurance, exhaustion, slowness, and low activity. In patients who are positive for a frailty phenotype, I have 3 or more criteria present. And patients who are intermediate or pre-frail have 1 or 2 criteria present. And as expected, the survival of the frail population is worse than in the non-frail population, and also we see a shorter time to first hospitalization or death in frail patients compared to non-frail patients, and also not unexpected, a worse outcome in patients with a high frailty score compared to those with a lower frailty score. So how about symptoms in old and frail patients on hemodialysis or chronic kidney disease? This is from the KDIGO, a controversies conference on supportive care in chronic kidney disease. Uremic pruritus is present in about 40% of patients. 25% experience severe pruritus. Sleep disorders in about 60 to 80%. Restless legs in about 10 to 20%. Anorexia, close to 50%. Nausea, 50%. Vomiting, constipation, diarrhea. Depression, around 25% in the CKD population, and pain present in close to 60% of the patients. This is an analysis from a smaller group of patients who were managed conservatively and in the last month of life. You can see that symptoms like fatigue, itching, drowsiness, shortness of breath, swelling arms, pain, dry mouth, anorexia are very common, and also very distressing. But symptoms like worrying, feeling sad, feeling nervous is also very common, but not as distressing as other symptoms in these conservatively managed patients with end-stage renal disease. How about the care of old and frail patients with end-stage renal disease? Well, we heard something about this before. There are some current controversies. Should all old and frail patients with end-stage renal disease be recommended dialysis? Is survival better or worse for some old and frail patients with dialysis or with active conservative care? How about quality of life, symptoms, and hospitalization? We still need to define what active conservative management should be. And there still remains some confusion about when dialysis can be considered an active treatment when it can be considered as a palliative treatment. This is a study that was mentioned in the previous talk. It was published in Clinical JSON 2 years ago. It compares conservatively managed patients with those on renal replacement therapy. There were 107 patients in the conservative group and 204 in the group of patients who had renal replacement therapy. The mean age in the conservatively managed group was higher, significantly high, but there was no differences in comorbidity scores, cardiovascular comorbidity, or renal diagnosis. The eGFR at the time of decision was a bit higher in the conservative group, but the rate of progression was similar, and patients who actually started on hemodialysis did so at a GFR of 8. And this is the survival curves in years in patients over 70 years treated conservatively or with renal replacement therapy from decision, is from treatment decision, from eGFR 20, eGFR 15, and eGFR of 10. And you can see that in all those comparisons, patients on renal replacement therapy had a longer survival than patients who were managed conservatively. But if you stratify for age, this is the group who was between 70 to 79, and this is over 80. You can see for those who are 70 to 79, the same pattern, but for those who are over 80, there are actually no significant differences in survival between patients managed with renal replacement therapy compared to those managed conservatively. And also if you stratify for comorbidity, those with no or intermediate comorbidity had better survival with dialysis, whereas the difference was much smaller in those with severe comorbidity. This is another comparison from NDT a few years ago, also showing the same pattern. Patients with low comorbidity who are more than 75 years old have a better survival with renal replacement therapy, whereas there was no difference in survival with high comorbidity scores. And also for the total group, the same pattern. So for the vast majority of patients with end-stage renal disease, dialysis provide a huge survival advantage. However, in those who are over 75, maybe 80 years of age, this advantage may be restricted to those without high comorbidity. So dialysis is likely to be beneficial in many old patients, especially those with low comorbidity and those with rapidly declining renal function, whereas conservative management may have a role in old patients with high comorbidity and slowly declining renal function. But an individualized approach is obviously necessary, and it's also very important to take quality of life and hospitalizations into consideration when you do these comparisons. Most patients want to discuss end-of-life care and talk about symptoms and place of care in the last month of life, and it's known from previous studies that timely advanced care planning leads to fewer hospital visits, greater use of hospice facilities, and increasing chances of dying at home. So shared decision-making is recommended to align treatment with patient and family goal, but treatment options often change over time. So shared decision-making requires a flexible approach of re-evaluating to ensure that the goals of care and treatment plan remain aligned with the patient's preferences. So patient opting for conservative, active management should be offered ongoing support by a multidisciplinary team, including the community, primary care, and hospice services, and full or near full medical treatment, including control of fluid and electrolyte balance, correcting anemia to avoid transfusions, and provision of appropriate palliative care and end-of-life care. So conservative active management involves a shift from efforts to prolong life to efforts to focus on quality of life and symptom control. This is a study from the National Registry about the last week of life in patients with chronic kidney disease. It's by Lena Axelsson, a former PhD student of mine. She's now a postdoc in Stockholm. She used the Swedish Register of Palliative Care, in which registered nurses and physicians complete a web questionnaire after death. The data are linked to the Swedish Causes of Death Certificate Register, and patients in which chronic kidney disease was reported as cause of mortality or underlying cause of death were included, and altogether 472 patients were included in this analysis. The mean age of these patients was 82 years, 60% were men, and in regard to place of death, about one-third of these patients with chronic kidney disease died at the hospital. One-third died in long-term nursing homes, and only 11% of these patients died at home. So the symptoms during the last week of life, it's interesting to see that many patients actually had no symptoms. No pain, no rattles, no anxiety, confusion, nausea, or shortness of breath. Some patients had symptoms, but they were totally relieved. Some were partly relieved, and actually only a few patients had symptoms that was not relieved, and that was mostly connected to confusion. This is different aspects of communications with patients dying on dialysis. Had end-of-life discussions with patients had taken place in 41% of the patients, and end-of-life discussions with family had taken place in 71% of the patients, and the patient preference for place of death was met in 41% of the patients, and many were unknown. So was someone present at the moment of death? No, 18% of the patients actually died alone. Family members were present in 35% of the cases, healthcare professionals 29%, and healthcare professionals and family members in 16%. So this is the thesis by Lena Axelsson that she presented. Living with hemodialysis close to death, patients and close relative experiences. And the aim was to describe inner thoughts and feelings relating to death and dying when living with hemodialysis approaching end of life. So she did a qualitative analysis. It's in-depth, long, in-depth interviews with patients. She selected 8 frail patients who were between 66 to 87 years old. They had many comorbidities, had been on dialysis for 1 to 7 years. They were followed for 1 year. There was a total of 31 interviews, and all patients lived at home. And they were given the open question, please tell me your experiences of living with illness and hemodialysis. So 3 themes appeared in these interviews. One was being aware that death may be near. The second was adapting to nearing death. And the third was being alone with existential thoughts. So the first including being reminded by the deteriorating body, being reminded by conditions of death of fellow patients, knowing hemodialysis as a border to death. And these are some quotes from these interviews. You see other patients on the dialysis ward who have problems. You notice how they deteriorate, and you hope that it won't last long. You think, what will happen to me? What will the end be like? That's on your mind. So the second theme included looking upon death as natural, preparing to face death, hoping for a quick death, repressing thoughts on death and dying. Well, it isn't this week anyway, I think. But sometimes I have to. I realize that it will happen one day. And then I wonder which day will be the one. When I can't walk, when I get an infection they can't find, when the medicine has no effect, and then maybe they will lose interest in doing anything, and, well, I can't do much about it. I hope it won't be too drawn out. And the third theme included wish to avoid burdening family, lack of communication with healthcare professionals, hemodialysis withdrawal as a hypothetical option. I asked, what will happen if I quit hemodialysis? The nurse, just looked at me. You'll die, he said, and left. Well, that I knew, I thought to myself. So even if death is expected, patients with dialysis have unmet palliative care needs. The patient's last week of life often include insufficient support, symptom assessment, and relief and lack of end-of-life discussions with patients and families. And there are remaining challenges in the provision of care for dying patients with end-stage kidney disease and a need for integrated palliative care. Thank you very much for your attention.